information.
Thank you, Jean-Marc. Good afternoon. It's lovely to be here. Short-term outcomes is all we've got about stature increase surgery. There is no mid-term or long-term published evidence at the moment. In the next minutes, I'm going to be sharing with you what I have come to realize about this treatment in relation to patient selection, outcomes, problems, and I will share some future perspectives of mine. We've been doing 6 cases on average every month in the last years. Currently, we're processing 140 patients, femurs and tibias, precise nail, Gieser nail, Stryde nail, with a minimum follow-up of more than 2 years. This substantial experience has already been shared in various fora in the UK and elsewhere in Europe in the recent years. These are difficult patients for specific reasons. They have their psychological symptoms which may prevent them from appreciating a good outcome or may reduce their compliance. This lady, for example, after having lengthened successfully femurs and tibias, she couldn't come into terms with the fact that she had less than 4 millimeters length discrepancy. Some others, not her, some others have complained about the shape of the callus. So they are demanding, as Dr. Baumgart said. They are well educated, which means that they need more time for explanations, and sometimes they are not compliant because they think that they understand better some things. And because they are young and physically healthy, it's more difficult for them to tolerate pain or to accept a limitation in their functional outcome. For all these reasons, in the UK, we have robust guidelines about cosmetic interventions of all sorts. The surgeon is obliged to assess the mental state of the patient, and if there are concerns about the benefit of the surgery, the patient should be referred for psychological assessment. In order for me to abide with these requirements and with the medical ethics, I have implemented an assessment which starts with 2 appointments at least. I assess the body dysmorphic condition with COPS questionnaire, and I have a medical history questionnaire in order to obviously scrutinize the patients about pre-existing conditions which could have a deleterious effect on the outcome. COPS questionnaire consists of 9 questions rated from 0 to 8. It was developed in the UK as a screening tool for body dysmorphic disorder prior and after any cosmetic intervention. Scores more than 40 strongly suggest body dysmorphic disorder, and consideration for psychological referral should be made. But is this enough? I know that a percentage of patients lie in the COPS questionnaire. They don't usually lie in the medical history because they are afraid of risks and dangers. Relative contraindications need always an individualized approach. For example, if someone is a bit overweight but with good upper body strength, they might be still suitable for this treatment. And how do I know from the beginning who is going to be compliant and who is going to be able to appreciate a successful outcome? I have no better answer than saying that I just use my anecdotal experience and some red flag questions and responses in order to make my final decision. Let's see how all this works. 6% of the patients excluded and referred for psychological assessment. 1% is excluded for medical reasons. My experience is that generally patients with medical problems, physical problems, they don't reach out for this treatment, for this surgery. COPS questionnaire at the final follow-up, 11.2. I remind you, 40 is the threshold for potential body dysmorphic disorder. So there is an improvement there compared to preoperatively. Redo question. Would you do it back then if you knew back then what you know now about this surgery? A staggering 94% says probably yes, definitely yes. 6% says no. Is this satisfactory? I think it is, but I always look ways to improve it. Proceeding to function, there is inconsistent reporting of outcomes out there. Most authors focus on bone healing and lengthening parameters. Some others focus on range of movement and weight-bearing timing. So there is a lot of inconsistency. We don't really know how success in stature increase surgery looks like. In my opinion, probably looks like relief from body dysmorphic disorder symptoms with good physical function, having achieved the set lengthening goal in the scheduled time without unplanned interventions. In our clinic, we collect subjective outcome scores and objective clinical measurements at regular post-op and preoperative and postoperative intervals. We use the Disability Rate Index score, DRI. We use it widely when I was in Oxford. It consists of 12 questions related to activities of daily living, rated by the patient themselves in a visual analog scale mode, and then a percentage rate is calculated. UCLA activity score, we introduced it a bit later in our series, 10 questions about the intensity and frequency of physical activity, rated from 0 to 10. And of course, we measure the range of movement of the hip, knee, and ankle joints at regular intervals. Some results. DRI preoperatively 7.28, at the final follow-up 11.9. Just to give you an idea, in the validation paper, healthy individuals rate 0.8. If we compare this with the 7.28, which is the preoperative score in our physically healthy patients, there is a discrepancy. I don't know how to decipher this. My explanation is that it has to do probably either with cultural differences in the way patients from cultural backgrounds interpret the question, or the body dysmorphic disorder itself may affect the way patients perceive their function, their body function. Range of movement. There is significant improvement at the end of the lengthening phase in the knee and hip and ankle flexion. But at the final follow-up, which is, at the time before nail removal, which is when we examine the patients again, the few that have returned to us certainly remain within functional range of movement. A picture is worth 1,000 words, so a few videos to give you an idea of how these patients move the day before the nail removal. They may not notice, but I sometimes notice a very mild Trendelenburg gait or position, and they may complain occasionally for mild ache in the trochanteric area, which is another reason why the nail should be removed. With regard to lengthening and bone healing, these patients lengthen a lot. It's not like other published case series with mixed unilateral and bilateral cases. These patients lengthen an average of 74 millimeters in the femur and more than 50 millimeters in the tibia. 86% reach their goal. The remaining reach more than 90% of their set goal. Lengthening index, 14 days per centimeter in the tibia, 11.5 days per centimeter in the femur. Slow for low is my motto recently, because I realized in a few cases like this really small girl from China, actually, who was adamant about lengthening 7 centimeters in the tibia, which in my mind sounded like huge lengthening. But she was very determined, very put together. She stayed with me for 5 months. We lengthened very, very slowly, 7 centimeters with 0.3 or 0.5, 0.4 millimeters per day. At the end of the lengthening period, you can see no ballerina foot, no equinus deformity at all. So slow lengthening for low complications. Bone healing index, 50 days in the tibia, 41.6 days on average in the femur. About pain. There is no pain on the first postoperative day. I know that you may not believe me. Patients don't believe me when I tell them before the surgery. Thanks to a combination of spinal and general anesthesia, we have no pain on the first day. During the lengthening phase, there is not a lot of pain. It's not the intensity, it's the duration. Having a pain every day for 3 months can be mentally tiring. 50% of patients take less painkillers than what I prescribe them. During the lengthening sessions, there is some pain as well, a bit more with G-nail, as expected, but both implants, Precise and G-nail, require support from a nursing team who knows how to teach these new skills to the patients and make them confident with executing this routine every day. The idea is to make them independent, not always rely on the team, but the team should be available for as long as needed. Manipulation under anesthesia, which was reported which was reported in the first paper 30 years ago with albigia nail because of pain, we have become predictable with this. 6 patients of the 76 G nails, 7.8% required this one session of lengthening under anesthesia, and just one session, a few minutes, and then the patients are very comfortable and without pain for lengthening for the remaining lengthening period. At final follow-up, as I mentioned already, there is mild occasional pain in some patients. Proceeding to complications, 2 bent nails causing malalignment and treated with exchange nailing, 1 tibia malunion treated with plate fixation at the time of implant removal, 2 broken nails treated with exchange nailing, 4 delayed unions treated either with weighting and teriparatide treatment, or in 2 cases we did augmentation with percutaneous screws. 1 severe equinus deformity in another patient from France who lengthened 7 centimeters in the tibia in France. He left Athens soon, and he developed this severe equinus deformity and came back for Achilles tendon lengthening. 1 precise nail not lengthening because of peculiar curvature in the intramedullary canal, so I removed it. I used the ridge trimmer from Guichet nail set in order to rim the canal, resent the precise nail, and it worked perfectly. 1 compartment syndrome of the anterior compartment of the tibia, 3 loosened screws, 2 deep vein thrombosis, 1 bilateral hip abductor contracture in a patient with a history of oily injections of some type in Asia in his childhood. A few comments about the issue with Stryde, because we use Stryde in this series. I was one of the first to notice it in London in December 2019 when I saw these images in one of my patients. I reported. Many papers followed. We also contributed our experience with our series in 2022 in the British Limb Reconstruction Society meeting in Brighton, in the UK. More than 70% of our patients had lesions, more than half of them bilateral lesions, more than half of them had late onset of pain. What's the aftermath of this case, of the Stryde case? It's not the first failure in history of orthopedics. It won't be the last. This is how science progresses. It remains unanswered in my mind why it was not detected earlier in the United States, given the fact that it had been used there for 1 year before it came to Europe and other places in the world. What are the long-term implications? I was pleased to see a few months ago that Dr. Rosbrook reported that there is no ongoing pain after the removal of the implants. I do have, though, this case, one of the 36 Stryde nails from Italy, 4 years after the surgery, complaining of localized pain. He's looking to find a solution with his doctors there. He sent me recently this CT scan, and he's collecting information in order to find a treatment for this. I think that there were lessons learned about product marketing and treatment marketing in general as a result of this case of Stryde. And in my experience, albeit derivative nails at the moment, and given the fact that the first experience with precise marks in the US, from what I understand, is rather discouraging, albeit derivative nails remain the only reliable and proven weight-bearing lengthening implants. I think high dysphoria is a serious underdiagnosed condition, more like anorexia or bigorexia. Patients suffer a lot, and they are prepared to spend time and money and risk themselves for a treatment. I think that psychologists will need to research more in order to help us understand what is the role of surgery in this treatment, and our goal as surgeons or as orthopedists is to offer a safe surgery to them, to those who really need it and who will really benefit from it. I think it's my generation's job to standardize the methods and the protocols of assessment and treatment. And in my opinion, we should start with a consensus on the type of data that we collect and the format we present it, in order to hopefully at some point have some meta-analysis. Thank you for your attention.